I think that kind of whenever we talk about a topic like neuroprotection and kind of all the changes that have taken place in all the things that we've tried to do over the years that have been variably successful and unsuccessful, it's good to start out, and that's why I'm happy that Sherry asked me to talk about this kind of as a first talk for a day in talking about neuroprotection, about really how the brain develops, because basically without understanding kind of what's going on in kind of the embryology of central nervous system development, a lot of the stuff that we do really doesn't make sense, number one. And then number two, there are certain things that we're not going to ever be able to help. And there are certain things that even if we really screw up, the groundwork or the framework of development, of neurodevelopment, has already been set so that even our screw up isn't going to ruin things. And so what this really gets to is what Dr. Volpe, who's kind of the guru of neonatal neurology, kind of talks about as critical periods or critical times in brain development. And what he means by that is that, you know, as we know, for example, with folic acid, if a mom waits until she misses her first, second, third period to realize that she's pregnant and says, whoops, and now starts taking her folic acid, well, the horse is out of the barn, or whatever the expression is already, for myelomeningocele. And so what we really need to think about is when in that developmental timeline, through embryogenesis and fetogenesis, things take place. Early on, when the central nervous system is kind of starting to develop, we go basically from a stage of primary vesicles with 3 primary vesicles to then 5 primary vesicles, and those vesicles with constriction will form the cerebrum, the cerebral aqueducts, the pons, the cerebellum, and the medulla. So these major critical time events that Volpe and others talk about are primary neurulation, prosencephalic development, neuronal proliferation, neuronal migration, organization of the neurons, and myelination so that messages can get from one part of the brain to another quicker. One of the important parts about that, in addition to understanding what each of those areas are, is looking at when they take place. And so we can think of, as folks who work and deal with neonates, and especially preterm neonates, that a lot of this we are not going to be able to affect at all. We might be able to affect through early intervention services and through intervention services how significant the deficits created due to defects in neuronal proliferation might be. But if there's a defect in neuronal proliferation, we're not going to be able to stop it. So there's basically 2 things to think about with primary neurulation, actually with neurulation in particular, primary and secondary. We all kind of start out as this kind of amorphous plate. And the amorphous plate has those 3 layers, if you remember back from school, of ectoderm, mesoderm, and endoderm. And the mesodermal notochord induces the neural plate, which will become ectoderm, and the neural plate then will fold over to become the neural tube, and then the neural crest cells. So the neural tube will eventually become the brain and spinal cord, while the neural crest cells become the dorsal, the sensory, and the autonomic ganglia. Does stuff ring bells from way back when that you were hoping you could have forgotten, but you can't? Then there's actually secondary neurulation, which is basically the tail end of the spinal cord. So the tail end of the spinal cord is actually initially solid, and by a process of kind of vacuolization and canals forms as the vacuoles coalesce into canals, you get this central canal that kind of runs down from the thoracic lumbar spinal cord down to the lumbosacral cord. And then what ends up happening is you get a regression of some of these caudal cells. And as they regress, you kind of get the end of the spinal cord, those fibers that kind of run back, the conus and the phylum. Those terms familiar to everybody or not? And the reason that the conus and the phylum should be familiar to us is that when we see the sacral dimples and when we see the little tufts of hair and we get the MRI of the back and or the ultrasound of the back, depending on what the radiologists want, because we're concerned about tethering, it's those parts of the conus and the phylum which kind of get caught up on the vertebrae, which really cause the tethering. So what does this look like pictorially? Well, at about 18 days, we have this neural plate, which is kind of starting to fold over. At the head end, we have the brain. Then there's the neural fold, which kind of starts in the middle. And then we end up getting the neural tube, and it kind of goes in a zipper-like fashion up toward the brain and down toward the spinal cord. What happens if this infolding doesn't take place? Something that I suspect none of us have seen, or maybe somebody have seen, is if it doesn't take place at all, and you end up with what remains just a neural plate, you get a craniorascesis totalis. In other words, if you look at the back of a fetus that's born with that, you just have, it's generally an uncovered area of just neural tissue. If the upper part of the zip ring doesn't take place, we get anencephaly. If the lower part doesn't take place at all, you get a myeloschisis. If the zipper gets stuck on the way up, and you get an incomplete closure on the way up, basically you get an encephalocele. And if the zipper gets stuck on the way down, you get a myelomeningocele. Again, if you remember when these are taking place, when these events are taking place, if you start trying to prevent spina bifida at 6 weeks post-conception, you will be, I'm guaranteeing you, you'll be unsuccessful. So let's go through some of these things, because some of them are things that we'll see in the nursery. So anencephaly, everybody's seen an anencephalic baby, or who has not seen an anencephalic baby? Raise your hand and be honest. Okay, so everybody has seen an anencephalic baby. Essentially, it's a fatal condition with 100% mortality in the first months of life. Actually, in the 1980s, there was discussions with the American Medical Association about whether or not there should be a redefinition of brain death to include these kids as brain dead, so that their organs, especially their hearts, could be used for harvesting for heart transplants. There was a lot of discussion about it, and eventually the ethicists decided no, but there was really quite an uproar by at least some parents I know that they wanted something good to come out of these otherwise incredibly difficult pregnancies. And everybody's seen it, so this should be old hat. So here's the picture of a baby with anencephaly, and what we want to think about in this picture for this talk really is thinking that what happened here was that overfolding of the neural folds as we got toward the second half of the first month of pregnancy didn't take place. Probably the most common of the disorders of dorsal induction is myelomeningocele, and depending upon the level at which the zipper got stuck is going to depend on the amount of loss of motor skills and sensory skills that your child will have. If you think back about the nerves coming off of the spinal cord, it's one of the reasons why essentially 100% of kids with myelomeningocele will also have problems with incontinence, because rectal tone and bladder control come off low from the spinal cord, so all these kids are going to be affected. What we need to think about with myelomeningocele is that not only the glob that we see of the myelomeningocele itself on the kid's back is affected, but all of the nerves caudal to that are also going to be affected. So the level where we see the spina bifida when we examine the kids, that's going to be the level below which the kids are going to be affected. What will end up happening is, from a very basic standpoint, is that the higher the level, the more difficult the ambulation. So if you have a sacral myelomeningocele, most of those kids with some orthotics of different types are going to be basically what we call community ambulators. So they'll be able to kind of walk around they'll be able to go to Westroads, they'll be able to go to Oakview if it stays open, and at least kind of get around from, kind of depending on how distant it is from one store to the next. Could be impossible for most of us to get from one store to the next open there. With a little bit higher level, the kids are going to be what we call household ambulators. So basically, they're going to be able to walk around the house those short distances, but if you get them to, if you try to take them out shopping, or if you try to take them out just for a walk, they're going to need some kind of devices, some kind of walkers, a gait trainer or whatever, to kind of get them around from one place to the next. Then there are those who are going to simply be work on ambulation with OTs and PTs like Sandy, who's sitting there hiding in the back of the room, just to kind of get enough work with their musculoskeletal system, so that they, and also developmentally, so that they can kind of be up, seeing the world the way the rest of us do. Now, one of the things to understand about spina bifida also is that it is not simply, generally in most cases, an issue of spinal cord and sensory motor and GI and GU issues below the area of the lesion. Somewhere around 3/4 of kids with spina bifida are going to have brainstem malformations. With that, there's going to be poor myelination. Some of the cranial nerve nuclei are going to be hypoplastic. There are also approximately 90% who have things which we'll talk about in a little bit, like cerebral cortical dysplasias, heterotopias, which we'll talk about, which are basically gray matter arrests sitting in the white matter, and abnormal sulci and gyri within the white matter. And finally, especially those kids with lumbosacral spina bifida and above are going to have Arnold-Chiari malformations. And the Arnold-Chiari malformations are felt to be what is associated with hydrocephalus in these kids. The treatment of hydrocephalus has also kind of been an issue with kids with spina bifida, and there are those who were advocates of in utero surgery for spina bifida, and one of the major outcomes that they were looking at was incidence of hydrocephalus and subsequently the need for a VP shunt. The reason this becomes an important issue is that a lot of earlier studies have shown that the number, that once you end up with a shunt, especially with shunt infections, that's one of the keys that causes decreases in IQ in this population. So if we could repair the spina bifidas in utero, not have to have hydrocephalus, not have to have a shunt, we could get better adaptive functioning in the kids. The issue, the results of it have been less than clear. One of the things seems to be that some of the neurosurgeons have been more hesitant to shunt kids who've had in utero closure, and so the data has not been real clear. Clearly, even if you close the defect in utero, you're not going to improve, you ought not to improve significantly the motor deficits, although there's some who believe in a second hit theory. And the second hit theory is that during labor, the increases in pressure with contractions and with a vaginal delivery, although the data again is not clear, can cause more damage to even those surviving neurons in the lower part of the spinal cord. So you might get some improvement in leg function if you close the defect in utero. Still, I think that the verdict is certainly out, and it is certainly not standard of care in any way to be closing these defects in utero. What does all of it look like? Well, this kind of takes us through kind of where we've been then, basically. There's the neural plate going to the neural folds, going to neural grooves, and then a closed neural tube. That's what our normal spine looks like at birth. If we have spina bifida, We get the spinal cord instead at that level of the back instead of the vertebrae sticking out, and there's our baby with spina bifida. And then this is kind of what we've all seen. If we look at those disorders of what Volpe has called occult dysgraphic states, and these are basically the kind of caudal or secondary neurulation. We have a group of less severe outcomes with a myelocystocele, kind of a cyst in the lower spinal cord, diastenomyelia, which is basically a splitting of the spinal cord, meningocele or lipomeningocele, kind of a big fat glob like the lipoma, the dermal sinus, and the tethered cord. And these are kind of by degree of severity. Most of these we can pick up, we hope we can pick up in the nursery basically by skin abnormalities, by abnormalities of the skin centrally along the lower back. So what are the features that we see with these? Usually abnormal hair collection, subcutaneous masses, hemangiomas or skin tags, and a cutaneous dimple or tract. I know Dr. Puccioni and the folks at Children's, it seems as though they're kind of waiting a little bit longer and longer really to address these, waiting to see whether or not the kids are really going to have significant problems with it. So we've now kind of started to create the central nervous system. The next thing is, now that we have all these little vesicles, how do we make these vesicles, especially at the rostral end, become the brain? Well, the next step is kind of taking that most forward part and going through prosencephalic development. What a lot of this is like is kind of like building a house. Part one is we bought the lot and kind of started to dig things out. Now we're kind of starting to lay some of the foundation. So this precortal mesoderm, that which is in front of the developing brain, induces the formation of the face and the forebrain, so that many of these issues of prosencephalic development will have abnormalities of the face with them. We'll have very close set eyes. In fact, even when it's very severe, even cyclops, basically. With prosencephalic development, you have several stages of cleavage, and those several stages are going to divide the brain both into its relatively symmetric halves and also divide the brain into its progressively more caudal parts. If none of these divisions take place, you basically get a big blob at the front of the spine of the form neural tube, and you get aprosencephaly or telencephaly, kind of both very rare. If you don't get a cleavage in half of the developing brain, you get holoprosencephaly or holotelencephaly. Holoprosencephaly is probably the one that we see kind of more commonly. And as we're cleaving down the middle of this vesicle, you get areas of thickening, and these areas of thickening become the corpus callosum, kind of the connecting part of the brain right to left, the septum pellucidum, which is kind of a tissue-like formation which is toward the front of the brain, and septo-optic dysplasia, where you have where there's abnormalities in eye development. And I know Dr. Heichel is going to be talking about ophthalmology later today. So remembering that the prosencephalic development takes place by mesodermal induction that then affects both the face and the brain. You worried?
Okay.
You sure? Go have some coffee and come back when we're done. All the ultrasounds would have picked it up long ago. Okay. What we have here then is significant midline abnormalities with the eyes very close together. There'll be a single nostril in this kid. It's going to be a midline cleft as opposed to the cleft lip and palate that we usually think about. And so we look at this kid and we say, something's not right. And in fact, when we look at his brain, what we find is that indeed something is not right. We don't see the usual differentiation of right brain versus left brain. And what we see in the cut on your far right lower corner, that's like one huge ventricle as opposed to lateral ventricles, and the basal ganglia and the thalamus are fused basically because we didn't get that splitting right to left with mesodermal induction. If those three midline plates of tissue don't thicken correctly, you get a genesis of the corpus callosum, and so you're going to get poor communication right brain to left brain. Absence or abnormalities of the septum pellucidum, which can have variable effects, as can a genesis of the corpus callosum. It's sometimes found really just as an incidental finding on autopsy of typically developing folks. If the optic chiasm is also involved, and that's kind of the frontal part of the prosencephalon, if that's involved in addition to this commissural development, which normally goes to the corpus callosum, that's where you get septo-optic dysplasia. And kind of all the way back, this plate then goes into the hypothalamus. And if the hypothalamus is maldeveloped with this midline development, you get septo-optic hypothalamic dysplasia. So that when Dr. Heichel or whoever says he has very tiny and white optic nerves, suddenly we're doing an MRI to look for what his corpus callosum looks like, because when you have a thinned or absent corpus callosum, it can be associated with variable degrees of developmental delay, global, including cognitive and behavioral issues. And then the other thing that it will lead us to do is kind of looking at glucose, steroids, and things like that, because we might have hypothalamic involvement. And so some of these kids will end up being on growth hormone. Lots of them are on levothyroxine because it started with the eye exam that showed a small and white optic disc. One of the most common, a syndrome associated with a genesis of the corpus callosum is acardia syndrome, which is associated 100% in girls with a genesis of the corpus callosum, and then with that, infantile spasms, cerebral cortical heteroplasia, and costovertebral defects. So what we've done so far then is we have kind of bought our land to build our house, and we've kind of dug out the foundation with induction and the formation of the neural tube. We've kind of started to divvy it up by which room is going to be where. And now we need to kind of bring the bricks to continue to build the house, basically. And that is essentially neuronal proliferation. So we got all this nice framework for this house that we're building, but we got to build it out of something, and that which we build it out of are bricks or neurons if we're talking about people. The neuronal proliferation peaks at about 3 to 4 months, and there's an early peak, which is primarily neurons and what are called radial glia, which basically tell the neurons where to go. And then there's a later peak at kind of 5+ months that's primarily glial proliferation. And the neurons basically proliferate in what we call a to and fro migration pattern in an area right around where the ventricles are, what's called the subventricular zone. And this is kind of how it works, basically. So at the bottom of the slide is the inner surface of the ventricle. And we have in the subventricular ventricular zone, we have our neuron. It goes down basically to the ventricular surface, duplicates, kind of depending on where we are in development. Some of the cells of the duplication are going to go up to the intermediate zone, which is going to become the cerebral cortex. And some of the cells are going to go back up and go through the same cycle again. Well, what happens if that doesn't work? Well, if we have less of these proliferative units, basically, we end up with what's basically called a radial microbrain, and the genetics of it are clear. If these units are small, we have microcephaly vera. And microcephaly vera can be a familial autosomal recessive trait. So basically, you just don't have enough neurons. If the baby's head size is okay, we're good. Okay. And it can also be caused by teratogenic factors like radiation, fetal alcohol syndrome, rubella, or it can be sporadic. Some of the kids with familial microcephaly vera can have very typical looking development early on, but then later will show some more delays. Although there's some, although there's some kids who, even though their heads are really tiny, developmentally look pretty good. But again, we can see that if we're looking at microcephaly, we can talk about when mom is doing a lot of her drinking and or develops rubella can help tell us when the likelihood of developing microcephaly secondary to these decreased size of the proliferative units would take place. It's got to be in this kind of 2 to 4 month period, because that's when this part of development is taking place. You can also have too many neurons, and it can be isolated or associated with some growth disturbances. We often see macrocephaly with some of the neurocutaneous syndromes like neurofibromatosis, which is also associated with too many glial cells. Especially probably about 10 years ago now, it was noted that kids with non-syndromic autism, kind of autism just because, if you looked at their head circumferences, although most of them were not clearly macrocephalic, kind of above the 95th or 97th percentile, if you looked at 100 kids with Fragile X, their head circumferences seemed to be bigger than the head circumference of kids who didn't have Fragile X. And the question was whether or not there was macrocephaly secondary to too many neurons in those kids. So now we've got the bricks to the house, to our building site, and now we've got to get the bricks to where they need to be. The peak period of neuronal migration then is 3 to 5 months. And in the cerebral cortex, this takes place by what we call radial migration. And if you think of radial migration, what it looks like basically is like the spikes, the spokes coming off of a wheel in a bicycle. In the cerebellum, it actually takes place both like the spokes off a wheel and also kind of around the wheel. And so early on during that initial period of an increased number of neurons, we also get an increased number of glial cells, and these glial cells kind of go from the ventricular surface up to the cortical plate or the top surface of the brain and basically act as a spoke for a wheel. And what ends up happening is that when that neuron decides that, hey, I'm done trying to duplicate myself, time to get up to where I belong, it actually rides along one of those radial glial guides. These radial glial guides, after neuronal proliferation and migration is done, actually then become kind of support cells within the brain, or astrocytes. And this is kind of, again, an artist's perception of what it looks like. So at the beginning, at the 13th week, we have all the neurons kind of at the bottom and all these strands of radial glial cells kind of being set up. Over time, we get more of the neurons kind of going up there. And then by the 25th week, we're really starting to get the neurons where they belong. Thinking now, if we're talking about resuscitating kids in that kind of 23 to 25 week period, this is kind of what's going on in their brains at that time. And so periods of profound hypoxia, periods of profound hypotension are clearly going to affect this kind of process. In the end, then, this is what the development of the cerebral cortex looks like over time. We go from a ventricular zone to then what's called a marginal and ventricular zone, toward, by the time we reach term, to a marginal zone, a cortical plate, what's called the intermediate zone, a subventricular zone, and a ventricular zone. What happens if this stuff doesn't work? And now we're kind of starting to reach something that is not uncommonly seen, certainly in developmental pediatrics, and can often be picked up in the nursery. The general clinical correlates of these migrational disorders we often see early with seizures. The anatomic hallmark for this is an abnormal gyral pattern. If you've seen pictures of the cortical surface of a 24-week fetus, it just kind of looks really smooth. You get to 30 weeks and you start to see more of the expected gyral and sulcal pattern, until by the time you get to term, you have this incredibly complex gyral and sulcal pattern. And what's happened in the interim is you've had literally billions of cells going from the center with the ventricular zones out to the outside of the brain. And there's only so much surface area that's there in the ball as we get more cells there. And so there has to be some way to increase that surface area. And one of the ways to increase that surface area of the tennis ball or whatever is to go in and out and in and out and in and out all around, increasing our surface area, so that if the migration doesn't take place as expected, we'll see abnormalities of gyral development. In order of decreasing severity, we see schizencephaly, lysencephaly, polymicrogyria, and heterotopias. And we talked about we mentioned heterotopias before when we talked about those rests of gray matter sitting in the middle of white matter. And now we understand why a disorder of migration would lead to a heterotopia, because the cells started at the ventricular level. They were supposed to go up into the gray matter. They got stuck, and they're stuck in the white matter. This is a picture, a CT, of a kid with schizencephaly. And schizencephaly has several ways that we can describe it. It can be open-lipped or closed-lipped. Open-lipped is when so schizencephaly is basically there's a cleft in the brain, okay? Open-lipped is when it goes from basically the pia all the way to the ventricles. Closed lip is when it doesn't go all the way. It can be unilateral or bilateral, one side or both sides, okay? The most severe is bilateral open lip schizencephaly, so it's like an axe went through the brain, okay? The least severe is closed lip schizencephaly, is a unilateral closed lip schizencephaly. The way to tell this from a stroke, where you might see abnormal brain in the area of the middle cerebral artery, where the strokes are most common, is that where the abnormality is, you can see where these, on your left side, you can see where those white arrows are, is you can actually see gray matter. So this is not a destructive lesion. It's just cells that got lost and didn't make it all the way to the outside. Here's agyria, and basically this is a brain that didn't get the gyri, basically. So schizencephaly is usually described as open or closed lip, unilateral, bilateral. And again, the hallmark of most of these disorders of neuronal migration are seizures, cognitive delays, and motor delays. There's a couple of genetic etiologies of lysencephaly, and lysencephaly is basically a smooth brain. And it can be isolated. It's usually associated with chromosome 17, or you can have type 2, which is associated with a congenital muscular dystrophy. A lot of conditions are associated with these photopias, these kind of little rests of gray matter in the middle of white matter. You can see it metabolically in some disorders, and we see it in myotonic dystrophy, with the neurocutaneous syndromes like tuberous sclerosis and neurofibromatosis. It's seen in some of the multiple congenital anomaly syndromes like Smith-Lemli-Opitz, Cornelia-de-Lange syndrome. Very common in a lot of the chromosomal disorders like trisomy 13, 18, and 21. And it's also associated with toxin exposure like alcohol or carbon monoxide. Once we've gotten the cells to where they need to be, the next step is that we need to get the cells to talk to each other. Basically, we have to get the mortar that holds the bricks together. And this goes from 5 months to years postnatal. And so now what we're starting to see are conditions for which the extreme prematures and the prematures who we take care of are going to be affected by the care that we deliver, because these are things that are happening clearly in the period of fetal development where we can get prematures surviving with fairly good mortality statistics. And so we get the subplate neurons developing, we get alignment of some of these neurons, we have dendritic and axonal ramifications, and we'll talk about those and see some pictures of those in a minute, and programmed cell death with apoptosis. So for example, those bigger brains that we see with the kids with Fragile X, one of the thoughts is that, yeah, they get the regular number of neurons, but what ends up happening is that instead of the usual programmed cell death or apoptosis that we usually see in typical brain development, maybe they didn't have too many cells, maybe they didn't lose enough cells as they're supposed to during the organizational period. Well, this is kind of a cartoon of a neuron, and we remember that neurons have lots of dendrites and this one long axon coming off of it. If you look at the dendrites, normally what you see is a lot of these kind of spine, what they call dendritic spines, coming off of them. So that's a normal dendritic spine, and each of these spines are areas that are potentially places where the axon from an incoming cell or an incoming message is going to get connected to. Is there a difference between a normal dendritic spine and the dendritic spine that we would see in Down syndrome? And the answer is staring you right in the face. And if you can't tell that difference, probably in the wrong, beyond in the wrong field. You probably need to have Dr. Heichel check your eyes, because clearly there's a significant difference, and what we see is less dendritic spines and therefore less of a chance for one cell to talk to each other in kids with Down syndrome. This looks at the development of these dendritic spines as we go through development from early through number 5, which I think is in an older child already. And so what we see is an increase in the number and the complexity of those spines through development. And so again, look here and think of where we can make interventions, and think of where the kids are at 24 weeks in their dendritic spine development. Think of that Down syndrome child and think of the possibilities of how we can screw things up. This is the neuronal network of I think it was a 6-year-old child who who died in a car accident or something, and just look at the complexity of that compared to this complexity of a 10-year-old with severe mental retardation. And so we are now in an area of development where neuronal protection can mean the difference between these two slides. What are some disorders of organization, mental retardation, intellectual disabilities? This is an older slide. Intellectual disability is the politically correct term now. Down syndrome, Fragile X, Angelman syndrome, as we mentioned, possibly autism, and Duchenne muscular dystrophy. And so what are some of the potential disturbances then that can lead to disorders of organization? And again, now we've really reached the point that we're talking about what we can do in the nursery. Periventricular leukomalacia, ventilator dependence, hypothyroidism. And obviously, although it's more exciting to deal with ventilators, somebody has to fill out all the TPN sheets and things like that. And poor nutrition can theoretically lead to some of these disorders of organization, as can experiential deprivation. And here we kind of start talking about what about kangaroo care, what about parents visiting, what about noise, too much noise, too little noise, too much, too little light, too much light, all of those things that we kind of talk about in the nursery. And then the final step is that now that we've built the house, we kind of put in our doorbell or whatever, and we have to have a way for somebody in one room to be able to easily communicate with somebody in another room, for somebody outside to let us know they want to come inside. And myelination, or speeding up the ability of those messages to go from one room to another, from the outside to the inside, has a peak time from birth to years postnatally. It generally has a couple of phases, but it's also one of the reasons why when we have some of these kids that were wondering about developmental delay and the etiology of developmental delay, why it's a good idea to wait to do some of the things like the MRIs until they're about 18 months of age, is because what the radiologist will report to us on the 3-month MRI is that the brain is hypomyelinated, uncertain whether or not this is secondary to a neurologic condition or just immaturity. Why? Because the brain is still immature and that myelination is still taking place. So I've pretty much, in a lot of the kids that I see, especially kind of like in follow-up clinic, if they're showing some delays, really doesn't help me a lot to get an MRI unless I really see something very significant on their exam at 8 or 9 months, because I'm going to get one of these real equivocal, like kissing your aunt or kissing your uncle types of reports saying, yeah, it might be abnormal, I'm not sure, because the brain is still developing. There's some general rules with myelination, that the proximal paths myelinate before the distal paths, sensory paths myelinate before motor paths, paths going from one important part to another myelinate before parts that kind of connect two parts that are associated. The occipital poles myelinate before the frontal poles. Primary orders are cerebral white matter hypoplasias, hypothyroidism, paraventricular leukomalacia. So now we've really reached the point of where those things that we do in the nursery can have an effect. Early on, schizencephaly, maybe good OB care, maybe making sure mom's not drinking, using drugs, things like that, might help prevent that. Maybe OT, PT, speech and communication might significantly improve outcome, but in the nursery, we're not going to do a lot to help and or prevent that. This is a baby who clearly died with a significant intracerebral hemorrhage. I thought I would just kind of show, because Sherry asked me to talk a little bit about hemorrhage. So this is a coronal ultrasound of a baby with a nice grade 4 intraventricular hemorrhage. And it's clearly a grade 4 hemorrhage because it meets all the criteria that we need for a hemorrhage. It has subependymal blood. It has ventricles that are pretty much filled with blood, and it also has a hemorrhagic component in the parenchyma. So how do I know that? On your right side, all right, so here we have basically blood in the brain parenchyma. So there we are, and it's in the typical spot for that we see what used to be called grade 4 hemorrhages, kind of at the lateral border of the lateral ventricle. So if we had it bilaterally, it would be here. We have blood here in the ventricular wall and also going into the ventricle itself. And we have enlarged ventricles, so it meets all the criteria for a grade 4 hemorrhage. Now, there's grade 4 hemorrhages and there's grade 4 hemorrhages, okay? And what I would ask you to do when you see a report that might talk about paraventricular hemorrhagic infarction or a grade 4 hemorrhage, that you talk to Brady and you have Brady pull up the ultrasound itself, because there's hemorrhages and there's hemorrhages. Depending upon the amount of parenchymal damage that we have, we've seen kids with grade 4 hemorrhage who have horrendous outcomes, and we've also seen kids with what the radiologists were calling grade 4 hemorrhages that have wonderful outcomes. And when you go back and you look at their ultrasounds, at their MRIs, it's often simply a matter that the one with a terrible outcome looked like this, and the one with a pretty good outcome just kind of had a ditzel of blood over here. And yeah, technically it's a grade 4 hemorrhage because there's blood in the ventricles too, and there's some blood in the germinal matrix. Yeah, I guess I have to call it a grade 4 hemorrhage, but it's really mild. And so when you see that, before you scare the pants off the parents it's really good to talk to Brady or to talk to Tom and say, what do you think? How bad is this? And a lot of times the answer is wait till Sherry sees the kid in tips, because only the outcome developmentally is going to tell us the significance of that hemorrhage. Now here we have a coronal view without a lot of blood here, but we do see ventricular dilatation. So technically a grade 2 hemorrhage. Here again, if we see the arrows in the upper left-hand corner, so that is, again, parenchymal blood. And this is one of the nicer ultrasounds that I've seen of paraventricular leukomalacia. So paraventricular leukomalacia, of all the things that we see with ultrasound, is probably the best predictor of subsequent gross motor disease, generally cerebral palsy. But here again is a coronal view, and I like the, on your right here, and you can see here's the ventricle, and here's these 3 stair-step little cysts. And so this is cystic paraventricular leukomalacia. We have a cyst over here too. So why is this cystic paraventricular leukomalacia? Well, they're black, so they're filled with water, so they're cysts. They're in the ventricular area, so they're periventricular. In this area is white matter, so it's leuco, or white, and it's bad to have these cysts in the white matter, so it's in Latin or whatever language it is, it's mal, so it's cystic periventricular leukomalacia. So it's bad white matter that's sitting right next to the ventricles. And if we think of the old homunculus, this is right where leg fibers go as they go down the pyramidal tracts to the legs, and that's why spastic diplegia, tight lower extremities, is kind of a hallmark of the cerebral palsy that we see in preemies. Here's a baby who will probably be developing, it certainly has an abnormal neurologic exam at this age. Looks like he might have some macrocephaly, and we have significant head lag. And here she is at 2 to 3 years of age, and she has all the signs of a child with spastic quadriplegia. We can see that she's got some esotropia. Her hands are postured, so it means that her arm fibers have been affected, and she's showing extension and scissoring of her lower extremities, and so her likely paraventricular leukomalacia is significantly affecting her lower extremities. Here she is later on with kind of a C curved back. We can see that she can't straighten out her legs because her hamstrings are tight, and she has some fisting remaining with her hands. So when we look into the isolettes of our extreme preemies, there's a lot that's already happened that we're not going to be able to prevent, but there's a lot still going on developmentally in that third trimester that we're going to have a significant effect on. And the science isn't real clear now, but it's something that's really well worth trying to understand better and doing everything we can to prevent more damage from happening in what God planned on being a 40-week project, basically.
Really quickly talk to them about watershed infarcts and compare it to the sprinkler. How you kind of explain that?
Did everybody hear what Sherry asked?
I was just going to have him talk to you about watershed infarcts, because like he talked about IVH doesn't always tell us a lot about a kiddo. Typically, we have to wait to see how they're going to develop. But if they see watershed infarcts on an MRI, that can give us more information about outcome.
So basically, I like to look at when we look and see hemorrhage, what we're looking at, I think, is really more of kind of a placeholder for where there's been damage to the brain parenchyma. And when we see hemorrhage in preemies, say the 28-weekers, basically what ends up happening typically is that the nutrition, the blood supply to the paraventricular zone comes from further out in the surface with kind of penetrating blood vessels, kind of going down closer to the ventricle. And if you think about your yard, and if you're one of the few people in the world left who don't have automatic sprinkler systems, and you have to put out sprinklers for your yard, and you've got a fairly good size yard, and you put a sprinkler over here and a sprinkler over here, and you turn on the water, and you have one of these sprinklers that go kind of like that. What is happening is that you're really covering the whole yard. And in fact, in the center area, you're really getting lots of water, okay? If your water pressure goes down, what will end up happening is you don't get as much of a, the pressure goes down, the water doesn't come out with as much pressure, so it doesn't go as far. So now instead of going like this, you're going like this. In this area in the middle, which used to have lots and lots of water, lots and lots of blood, lots and lots of nutrition, now gets none to much less. When you have a preemie who doesn't auto-regulate his cerebral blood flow, that's exactly what happens with periods of hypotension. He is getting a very nice flow of blood and nutrition to all of the paraventricular area. He gets an episode of hypotension. This in-between area of blood flow, for this in-between area of ventricle isn't getting blood, so it gets damaged. As it gets damaged, like any tissue, it becomes sick, and as it becomes sick, it becomes an easy place to bleed. You bruise you hurt yourself, you're going to bleed. Older people bruise more easily than younger people. Okay, I've got more bruises than you, so I got thinner skin and such. And so that's what I look at for the hemorrhages. Now, once you get a hemorrhage in the periventricular area, because the blood is kind of oozed out to this sick area of paraventricular white matter, what ends up happening is that the venous return from the brain, which happens to go along where the ventricles are, now goes through veins that are running through this sick white matter which has blood in it. Well, the sick white matter which has blood in it is kind of constricting those veins, making that venous return more difficult. Does that make sense? So now we have basically, we had some we had a period of hypotension. The period of hypotension caused an area of the germinal matrix, the area right around the ventricles, to get sick. When it got sick, it got more friable. As it got more friable, the blood vessel stroma around it oozed and bled. And so now we have a grade 1 hemorrhage, basically. And through that area of hemorrhage runs returning blood vessels, returning veins from the white matter. Those returning veins are now running through sick brain. That sick brain with bleeding kind of expands because that doesn't normally have that much blood in it. It squeezes the vein, makes it more difficult for the blood to come back, increases pressure in those veins. As it increases pressure in those veins, they pop and bleed, and now you have hemorrhagic venous infarction, which is a grade 4 hemorrhage. That's what you see.
Does anyone have any questions?
All right?
Thank you so much.
Okay.